ERA-Net NEURON Lecture on COVID-19 and mental health. My name is Mali Storlichter. I am the coordinator of the ERA-Net NEURON, and before we see and hear our dear speaker of today, I would like to give you an introduction to the ERA-Net. NEURON is a network of funding organizations, of ministries and research councils and funding agencies. And over the past 15 years, funders from 28 countries have been working together with the European Commission to jointly fund and support disease-related brain research. So what do? We fund and we support translational research. That means research that starts with basic fundamental questions like genetics, cells, and molecules, up to clinical research with patients. We have topics in neurology like head trauma, pain, stroke, and epilepsy, but we also cover psychiatric disorders like depression, schizophrenia, or ADHS. We do a lot of different things. Our joint funding has so far amounted already to 170 million euros. We are funding 190 transnational research consortia, and in these transnational research consortia, around 800 research groups are involved in doing their research. But we also do lobbying. We try to convince our national ministries, governments, and the European Commission how important neuroscience is. And we offer interacting possibilities for researchers, stakeholders across Europe and also beyond. We have an entire program for young neuroscientists. We have an excellent paper award that we give every year. We have privileged access to high-class training and offer this to the young researchers in our funded research consortia. We organize workshops, poster sessions, and much more. And we also have an entire program for interaction with society. We involve patients in all our activities. We produce video clips on YouTube, and we have these lay lectures. And it is my pleasure to present to you Dr. Livia De Picker, who will talk about COVID-19 and mental health. And I would like to give the word now to Etienne Hirsch from INSAM France, who will tell you more about Livia. Thank you very much.
Thank you, Marlies. It is now my great pleasure to introduce our speaker, Dr. Livia De Picker. She's a psychiatrist specialized in, as you know, in mental health, but she's also an outstanding scientist. She is based in Belgium at the University of Antwerp, where she oversees an inpatient ward in psychiatry at the University Psychiatric Center Duffel. She is also a clinical academic coordinator in this center, and she obtained numerous grants in several fields, including inflammatory processes in psychiatric disorders. Her work revolves on the interface of research, clinical care, and healthcare policy, focusing on synergies between these three domains and strategy for translational implementation of evidence-based policy. With 8 years of experience working in the field of immunopsychiatry research, Dr. Livia De Picker has become an influential early career clinician scientist who has been constantly promoting the field of biological psychiatry in Belgium, but also in Europe. Yet, she never forgets her patients, and her objectives are, as it is written in her CV, to improve patients' quality of life through a synthesis of mental health research, policy, and clinical care. During the last year, she has been strongly involved in the influence of COVID pandemics on mental health, and she will now share her thoughts about this topic. Livia, thank you very much for joining this lay audience conference, and thank you for giving this within the frame of ERA-Net Neuron. The floor is yours.
Thank you very much, and a big thanks to ERA-Net for this invitation. While we are waiting for my presentation to load, I just wanted to say that it's a real pleasure to be able to talk for a large audience. I really enjoy these kinds of lay lectures because I think it's really important as scientists that we don't just do good research, but also that we then use our findings to inform the policy and the public as well. So I'm going to be talking about COVID and mental health. And I should say I'm working in immunopsychiatry. So that means that I am researching the links between mental health disorders and the immune system. And so when the pandemic began about 2 years ago, we were actually very worried already at the beginning about what this was going to mean for mental health services and psychiatry. And we did warn governments about our concerns. And unfortunately, it is my sad duty about 2 years later to inform you now that we have been proven right. Not just once, not just twice, but 3 times over, we have seen that there is a big threat to global mental health caused by the COVID-19 pandemic. So my affiliations are at the University of Antwerp and University Psychiatric Hospital in Duffel, both in Belgium. And besides that, I'm also involved in a lot of different European organizations and editorial boards. We're doing also research collaborations with many different partners, including also partners from the industry. So I have collaborations with Janssen and Boehringer Ingelheim, but those are not involved in the COVID projects. So I'm not personally involved in development of COVID treatments or vaccines. So first of all, why do we need to keep talking about COVID-19? I don't know how many people are in this lay lecture, and I will probably find out at the end. But I have heard from several Congress organizers in the last year, stop submitting abstracts about COVID-19. People are tired of hearing about COVID-19. No one will come to that. And I don't think that's true. I think it's really important that we do keep talking about COVID-19 for 2 reasons. Firstly, because the patients are still here. Not only are there still new cases of COVID-19 infections, and the CDC has just reported that there is now a new variant out in Europe and the United States, but also there is still a very big group of patients who suffer from persistent symptoms with long-term symptoms after an initial COVID-19 infection. And these people are still seeking help, seeking treatments. And then secondly, despite the pandemic having taken so much away from us, there is maybe one little light to all of this. If we are smart about it, the pandemic can offer us the opportunity to finally understand much better why infections can cause mental health symptoms, because this is not new. We have seen similar things with other kinds of infections for many, many years, but it's been very difficult to study those at a wide scale. So hopefully by studying COVID-19, we can also understand more about other kinds of infections and why they cause mental health problems. So I've talked about the triple threat, and these are the 3 domino blocks that I have seen falling after COVID-19 hit the world. So firstly, how did the pandemic affect our mental health in general as a society? Then secondly, does COVID-19 infection cause mental disorders by itself? And then thirdly, what happened to the people who already had mental health disorders when they get infected with COVID-19? So how did the pandemic affect our mental health? Well, I'm sure it's similar in other countries as well, but at least here in Belgium, it seems like we have never heard so much about mental health as in the last 2 years. It's been everywhere in the media. Every week there is some item about depression rates, suicide attempts, eating disorders, etc. And all of that linked to the pandemic. And so, yes, already in the first year of the pandemic, we have seen also in the scientific literature, many studies reporting all on the same thing, increases in mental health problems in the general population. Mostly anxiety, depression, trauma-related problems, stress complaints. Now, of course, these numbers here on the right don't say very much if you don't know what was the baseline. What was the level of anxiety and depression in the society before COVID? So some studies have looked into that, and this is a very nice one, also from 2020, from the first year of the pandemic, showing that in comparison to the period before the pandemic, and this is the graph that you see in purple, the period during the pandemic, indicated in orange, shows a clear increase both in depression complaints and in anxiety disorders in males and in females. And on average, we could say that there is about a 25% increase in those rates across the different groups. And now these are not just people who have some minor complaints. These were people suffering from depressive disorders or anxiety disorders to a degree that would fit the diagnostic criteria of the psychiatric textbooks. And this study also showed that as between different countries, the rates were not actually the same. We saw higher depression and anxiety disorder increases in countries where the mobility had been more restricted by very strict lockdown measures, and also in countries where there were higher rates of COVID infections. So there seems to be both an impact of the different measures that were taken in a certain society, but also of the infection itself. This is another study from the United Kingdom where they compared 3 different periods of the pandemic: an initial first lockdown in the spring of 2020, then this summer period where there was a relative easing, loosening of the restrictions, and then a third period in the autumn with, again, a lockdown. And actually, if we look at the different rates of psychological distress, so these are all different age groups indicated here, compared to the baseline, which is the 0 in this graph, we see increases across the different age groups, but also in all 3 periods of time. So the mental health distress increased even if there was no active lockdown ongoing in a certain country. So we see more psychological distress, more anxiety, more depression on the whole. Yet at the same time, it seems that this has not become the huge tsunami of new mental health admissions that that some people were fearing or were warning for. So yes, on the one hand, these problems have been transient and for the most part have resolved. But at the same time, there are certain specific subgroups of individuals and people with mental health problems who we have seen a huge increase in admission rates, both referrals to emergency departments and inpatients admission rates. So for instance, this is research that just came out 1 month ago about the eating disorder admissions in a specific hospital in Barcelona, catering to child and adolescent psychiatry. And so here are the rates of the rates of eating disorder admissions to the emergency ward, starting from the spring before COVID-19, and then here the first COVID lockdown, and then the periods after that. And as you can see in the male children and adolescents, you don't see a huge increase, but in the young girls, and because the mean age here was 14 years old, there was a huge increase in new admissions, which wasn't really visible during the lockdown itself, but has really emerged in the last spring. So, and it's probably still going to keep increasing. So we're not yet seeing the total consequence, but it is very concerning, especially because very specialized services like this one for eating disorders were already understaffed, had already long waiting lists, and now it will just become a huge problem to treat all of those young children who are in need of care. And that's only the beginning of the problem, because as I have mentioned in my introduction, there is also the large problem of COVID-19 infection causing mental health disorders in people who have suffered the infection. And so, again, we were not surprised to see this, because already prior to our knowledge about this current virus, we knew that there were reasons to fear brain complications of COVID-19. And that's because even if this is a new virus, there were other viruses of the same family of human coronavirus that we have studied in the past and that have turned out to be invasive to the brain, which means that if they have the possibility to attack brain cells, that they will do that. And even in some kinds of these viruses, like the SARS virus, which is very similar to the COVID-19 virus, we have seen that the virus can stay in the brain even when it's long gone from the body. And that's probably the explanation why in some patients who had SARS or MERS, which is another related virus, which had local outbreaks in the past, patients sometimes had neurological and psychiatric symptoms weeks after they developed the initial respiratory symptoms. Now, of course, SARS-CoV-2, the virus of COVID-19, is not exactly the same as these previous viruses, but it's very similar. It has a high genetic overlap with those other viruses. And the main difference of this new virus is that it has a mutation that causes a stronger binding to a specific receptor called ACE2. And this ACE2 is present in the brain. It's present in particular in the centers of our brain, which are responsible for the regulation of breathing, of blood pressure and heart rate, for instance. So it's very likely that also SARS-CoV-2, the virus that causes COVID-19, if given the chance, will enter the brain and infect certain brain cells. And yes, it can reach our brain because initially the COVID-19 virus enters our body through our nose and then goes through our airway and our lungs. But in the nose, there is also a nerve that is responsible for smelling. And this nerve goes directly from your nose to your brain. And we think that this is the main route through which the COVID-19 virus, when you're infected, can enter your brain and then infect also potentially some brain cells. So it's definitely not a coincidence that this virus is also causing a lot of smelling issues and tasting issues, because this is exactly the nerve ending that we think is channeling the virus up into our brain. Now, before we go on with the explanations about COVID-19 long COVID syndrome or post-COVID-19 syndrome, so here are the official explanations or definitions according to the NICE guidelines from the UK. So the acute COVID-19 infection, this is what we mean when people have symptoms up to 4 weeks after the initial infection. Then there is this gray area in between zone between the 4 and the 12 weeks period where we would not yet call it long COVID, but maybe be wary and monitor well if it goes away. And then there is the real long COVID or post-COVID-19 syndrome where people have symptoms even beyond 12 weeks, where we can't find another explanation for that diagnosis or for those problems. And where symptoms can fluctuate, go on and off, but cause a lot of troubles for people who have that syndrome. And we are doing a little bit of research on that ourselves. And what we are seeing mostly in our study is that many people with long COVID or post-COVID complications, regardless of which kind of symptoms they have physically, they almost always also have one or more different kinds of neurological psychiatric complications. And these are the ones that we see the most: sleep problems, anxiety, depression, severe fatigue and cognitive problems. That means problems with memory and concentration. And usually if people have one of these, they will also have one other. So COVID-19 complications, they rarely present as just one thing. It's usually a cluster of different things and even a cluster of different organ areas, some respiratory symptoms, some neurological symptoms, all happening at the same time. And so there has been some research looking really at what are the numbers about this. It's very difficult to study this well, because of course this means that you would need to be able to identify everyone that had COVID accurately, and then also find out which symptoms they developed at which point in time. So there is few studies that have really looked at large groups of people individually. Most of the data that we have, especially the large-scale data, come from electronic health records like this one. So these are data from the United States, where they looked at 70 million people in the United States who had a positive COVID PCR at one point, and then investigated what are their chances of getting diagnosed with a new psychiatric or neurological problem within 6 months after the infection. And across the board, 1 in 3 people who had COVID-19 will get a new diagnosis of a neurological or psychiatric problem within 6 months. And that is huge, of course. And even more importantly, it's not just people who were in the hospital. So yes, the rates are a little bit higher in people who were in the hospital for COVID or who were in the ICU department for COVID, but even among non-hospitalized patients, patients who had a relatively mild initial infection, we still see very high rates of neurological and psychiatric complications. And if we compare that rate of complications to other kinds of infections, because as I said before, we know that this is happening with infections, and it was already the case also with influenza and with other kinds of viruses. So we see it's mostly mood and anxiety, and then at a much smaller scale, some psychotic problems, that the pattern of which kind of complications emerge is not so different compared to influenza or now here with the respiratory infections, but it's at a higher rate than with those other infections. So if we compare, for instance, with the regular flu, we have a 36% greater risk of neurological and mental health diagnosis with COVID-19 compared to the flu. And in many of those patients with some neurological or psychiatric complications, or even those without, who just have mostly somatic, so symptoms in the body, one of the main complaints has been problems with cognition, with memory, with concentration. And this has been a very nice study from Italian colleagues who have investigated a group of people who had COVID pneumonia at the very beginning of the pandemic, so in the spring of 2020 in the region of Milan. And they have followed them up, well, over 1 year already at this time, but the current data that I'm going to show you are from 6 months after the infection. So these are all kinds of different specific aspects of cognition. So there is the ability to memorize words, there is your working memory, which you use to remember something that someone told you before you are able to write it down in your diary. There is verbal fluency, the ability to find the word that you're looking for and talk at the normal speed. There is attention, information processing speed, executive functioning, which means planning and organization, and then psychomotor coordination, the ability to do different modes of things at the same time, or complicated tasks. So these are the scores that you would expect to see in healthy controls. And then they've compared this to patients with who had COVID-19. So not all of them have long COVID. So this is across the board of patients who have had COVID-19. And you can easily see that some of these fields, like the verbal memory, the working memory, the patients were not really performing any worse than the healthy controls, but in some other fields, like here, the psychomotor coordination, all this attention and processing speed, we do see decreases among patients even after 6 months. And then they also, interestingly, compared this to a third group of people who had a regular major depressive disorder, so basically a diagnosis of depression without COVID-19. And then here we see that in some cases, the patients with the depression are doing clearly worse than the other two groups. So here with the verbal memory and the working memory. But then for some of the other groups, some of the other categories, the issues experienced by the patients with COVID-19 are very similar to the issues that we would also see in patients with depression. So it's not quite the same as patients with depression, but on certain categories, it is similar to what we see in a major depressive disorder. So something is not going well in the brain of people who have had COVID-19. And of course, if we talk about the brain, then we hope to get also some imaging information from an MRI scan, for instance, showing us exactly what is going wrong. Well, this study from the United Kingdom has actually been unique in its type because they had baseline information from all the participants. So basically, they were already doing a large brain imaging study before the pandemic, and they had scanned with MRI about 800 people. So they had brain images of 800 people, and then the pandemic came. And then 2 years later, they looked at who of our people developed COVID and who didn't. And at the end, they had about 400 people who had COVID-19 and then 400 who didn't have COVID-19, and they scanned them again. So now we can compare the before and the after, both in people who have had the virus and then in people who have not had the virus. And what they saw is that there were in very specific regions, there was a mild, subtle loss of brain tissue in the regions linked to sense of smell and taste in the people who had COVID-19, but only on the left side of the brain. We don't know yet what this means, but it could be an explanation for some of these symptoms of sense of smell and taste problems that in some people persist a long time after the infection, but it could also provide some clues about these other kinds of symptoms that we are seeing, because obviously these brain regions are then linked to other types of regions where they could be causing additional problems. We are also not sure if this loss of brain tissue is caused directly by the virus itself, by the virus infecting brain cells, or if it is a consequence of the inflammation of the body's immune response to the virus. In any case, and regardless of what is the cause, it is clear that this is a big problem, and many patients, actually the large majority of patients, do not recover well from this. So in this study, which looked at almost 4,000 people from over 50 countries, after 6 months, 91% of the patients still had symptoms, and the most common symptoms were fatigue, so extreme tiredness, post-exertional malaise. This means that if you strain yourself, if you do exercise, or if you have a very challenging day with a lot of mental tasks being put on you, that you feel very sick afterwards and you need a lot of time to recover from that. And then the third most common complaint is cognitive dysfunction, as I've just showed you, so memory and concentration problems. And interestingly, in the large majority of patients, these symptoms can wax and wane, so they're not always the same, and there are like relapses triggered by exercise, by physical or mental activity, and by stress. Concentration memory issues were common across all age groups, so it's not just in elderly people, and so the large majority of people have not fully returned to work after month 7. So this is very worrisome, and I have to admit, when I got COVID myself a few months ago, I was most worried about this, about the post-COVID syndrome, because it's so unpredictable who will get it, who is at risk. Some studies have, of course, looked at risk factors and have come up with some of the answers. So we know that women are more at risk, people who smoke, people who are older with a higher BMI, people who had more symptoms in the first week or had shortness of breath in the initial infection. Then certain kinds of biomarkers in the blood can maybe also predict a little bit of the risk. people who already had psychiatric and neurological disorders or other health problems or a lot of psychological distress, and maybe also some genetic factors. So, okay, there are a few risk factors, but still at this point, we cannot predict at the individual level who will get this long COVID and who won't. So this was, I think, a very interesting study that came out a few months ago, looking at psychological distress before the infection. So as I've just said, we know now that this is actually a risk factor. Again, it's really difficult to prove this, but in this particular study, with a lot of people, 54,000 individuals in 3 cohorts, the large majority were women and a lot of them were healthcare workers. They did routine follow-up measurements of psychological distress every month in all the individuals throughout the pandemic. And then afterwards, they could obviously see who was infected with COVID-19 at some point, and then which people developed post-COVID conditions, which was about half of the total individuals who had COVID-19. And then they saw that if people had 1 or 2 or more types of distress before getting the COVID infection, that you have up to 1/3 or even 50% increased risk of getting a post-COVID condition. Again, we don't yet know what this means or what are the different mechanisms, but I think it's an important finding and something that we should take into account when we take public health measures to lower the risk of long COVID or post-COVID-19 related dropout from work. Does the vaccine protect us from long COVID? Unfortunately, no. So in this study, again, using electronic health records from the United States, researchers have compared people who were fully vaccinated against people who were unvaccinated at the time that they got the COVID-19 infection. And then here you can see the whole list of different symptoms that person can have, where with all these different risk ratios. So the dotted line here means the risk ratio is 1. There is no decreased or no increased risk. So that's the baseline. And the more the little dots go to the left, which that means that the risk is decreased. So basically you can say everything here at the top part, including from the mental health part, the psychotic disorder and the fatigue, here your risk is lower if you're vaccinated. But then everything here at the bottom part, including cognitive symptoms, sleep problems, long COVID in general, mood disorders, anxiety, headache, the risk is not decreased when you're vaccinated. So unfortunately, vaccination is still very useful and can help protect us against some of the COVID-19 complications, but there are still other complications that remain at risk when we get infected, even if we're vaccinated. So we cannot fully protect ourselves from it. Can we treat it? Also, unfortunately, right now, no, not yet. So this is the treatment algorithm that is currently in the scientific literature for neurological long COVID consequences. And basically what this says is that the clinician should first rule out that there is any other problem happening, that there is maybe another psychiatric problem or another neurological condition, or that maybe it is related to someone having to stay in the ICU department at some point. But if all of those other questions are no, then you have to diagnose it as neurological long COVID. And there is not really so much that we can do according to this guideline. We can try to rehabilitate people in a multidisciplinary context, help them with strategies to be able to function better and in the activities of daily life, maybe some support of psychological interventions, but that's not really treating the underlying problem. So there is reason to be kind of pessimistic about this, although not completely. So this is work also again from our Italian colleagues in Milan, who have done this very little pilot project on SSRI antidepressants in people who had post-COVID depression. So again, this is from the same group as I've showed you previously. They followed people who had COVID-19 pneumonia and then developed cognitive issues or mental health issues. So they just treated clinically 60 patients with post-COVID depression. This was 6 months after the initial COVID-19 infection. About half of them were women. The mean age was 54 years old. And also about half of them already had a psychiatric history, so might have been more vulnerable to develop these complications. They gave them an SSRI. This is a specific kind of antidepressants that is very much used in regular mental health care for 4 weeks and saw a 92 response rate. Now you have to know that the normal response rate to SSRIs in a regular group of people with depression is at most 30%. So a 92% response rate is actually higher than what we would normally see with these medications in depression. And of course, this needs to be replicated in other studies because, for instance, there was no placebo arm, it was not blinded. So this is not the full proof that it really works in post-COVID depression as well, but at least it's some hopeful sign that some of the symptoms we can treat. And therefore, we think it's also extremely important that if a person has a long COVID syndrome, that regardless of the complaints they bring to the clinician, that we should always screen them for depression symptoms and anxiety symptoms and insomnia symptoms, because at the very least, those we can treat. And that's actually a little bit of a problem because we've noted, and this is something that many colleagues have told me, that many people in the public are not really aware that COVID-19 can cause depression, can cause insomnia or anxiety problems. So this is why we are now collaborating with colleagues in France and also in Italy to develop an online platform meant for the wider public, for patients, family, for general practitioners, to give information about the mental health complications of COVID-19, but also give people already the tools to screen themselves so they can take that information to their healthcare providers. So it's not yet launched. It will launch at this address in 2023, but I have a little demo version for you. So as you can see, there is information about different kinds of symptoms related to COVID-19. There are testimonies of other patients that people may recognize themselves in. And then there is this little screening module where we can very easily, just by asking a few questions, get an idea of what is the situation of this person. So people write a little bit of text. And then there are some follow-up questions about how is the sleep, how is your stress level, how are things going at work, are you able to function well? Voila, and then it gives this little overview so people can see at one glance, this is your result, this is where maybe you should be worried. And then it can people can follow that up with standardized screening questionnaires, so questionnaires that we have selected because they're also used in clinical practice and in research, and they give a standardized idea of if the level of symptoms is sufficient to really meet criteria for a diagnosis. And if this is the case, then of course, we will advise people to seek help for that. So I'm now going to enter the last part of my talk about how people with pre-existing mental health disorders were affected by COVID-19. So this is a group of people that I think were not as much represented in the media throughout all of the pandemic. And in fact, at some point, I've even felt that we were mostly invisible with people in psychiatric hospitals and working with people with severe mental health disorders. Despite there being good reasons for them not to be invisible, because this is a press release that came out in January of 2021, out of all the different risk factors that we know can cause severe acute COVID-19 infection. So now we're not talking about long-term complications, but really about this acute initial infection where especially in the beginning, before the vaccinations, lots of people were hospitalized, put on incubators, or even dying from COVID-19. So the major risk factor for that, of course, was older age. But the second major risk factor, just below age, was a diagnosis of schizophrenia, which is a very specific severe mental illness linked with the development of psychotic symptoms. And even though it's not very common, it is still affecting 1% of the total population. So that's a very large group of people who have a big increased risk. And for them, there were really no specific resources, no specific campaigns to protect them against the virus. So I'm going to talk a little bit about our work and how we campaigned for more protection for these mental health patients. And this really starts in September of 2020. So this is the first year of the pandemic. In the autumn, we've just had the first wave. This is when we saw the first reports of increased risks of COVID-19 in people with severe mental illness. That's what SMI stands for, severe mental illness. So if you had a prior psychiatric diagnosis, you had an increased risk of dying from COVID-19. And then by December, as you might all remember, the first vaccine was approved in the European Union. And we saw in the scientific literature the first calls to give priority to patients with severe mental illness, because as you recall, in the beginning, there were not enough vaccines available for everybody. And all of the different governments had to make sort of a short list of which groups of people were going to get priority for the vaccination. So initially, some of the authors were stressing mostly ethical arguments. These people already have a reduced life expectancy. They're very vulnerable. They have an increased risk of getting COVID. But then we've also added to that additional arguments from the immunological point of view, because again, working in immunopsychiatry, we knew that many of these people with severe mental illness already have problems with immunity. Their immune cells are aging faster. So if age is the major risk factor and these people have older immune cells relative to their biological age, then obviously it's going to be a risk. And we were also expecting that their vaccine response might be lower because we had seen similar things with other types of vaccines. So we compared what the literature was telling us about risks in people with severe mental illness compared to other kinds of disorders that were in many countries on the short list to get priority, for instance, diabetes or chronic lung problems. And here are the different numbers of what we knew about the risk at that time. So a higher number means a higher chance of dying, where you see that the risk for the people with severe mental illness, 2.9, is actually higher than that of many of the other categories here. And so it's very striking and surprising that when looking at the different vaccination strategies at that time being rolled out in Europe, that we were not seeing many countries giving priority to severe mental illness. So here, tier 1, tier 2, this means that there is some priority for people in that category. So you see, for instance, with the chronic lung conditions, almost all countries recognize this as a risk group. But for the severe mental illness, it's just 4 countries. And those countries were these 4 indicated in the green here. So these were the only countries where we found in the national vaccination plans in February 2021 a priority mention for people with severe mental illness. Now, some other countries here indicated in the stripy, with the stripes, they didn't mention anything about severe mental illness, but they did give priority to people in institutions. And so some people with mental illness, if they were in institutions at the time, would have been given priority, but for all of the patients who were not in a hospital, not in an institution, there was no mention at all, basically. So this doesn't make sense. I've clearly shown you, and we've clearly shown policymakers, that patients with severe mental illness have an increased risk of dying, which is just as high or even higher as that of other kinds of disorders that are given priority. But this knowledge has not been translated into the vaccination strategy plans. Why? Well, I think for the most part, they were just forgotten. It seems that policymakers were just not aware of this increased risk, potentially because representatives of mental health, patients or professionals were not at the table in the committees where these decisions were being made. And also, unfortunately, when we were talking to policymakers following this work, we were met with a lot of stigmatizing and misinformed attitudes. So we heard things like, well, most patients with mental health problems are institutionalized anyway. So what's the problem? We are giving priority to people in institutions. Well, that's just not true. Across all of Europe, the number of long stay beds has gone down significantly in the last decades. And so the majority of people with severe mental illness are being treated in the community and are living in the community. Then also we heard, well, yes, we should give priority to these patients because, well, they have, behavioral problems and they can't follow COVID-19 restrictions. So it's better that we give them priority, which is obviously, I think it was well-intentioned, but actually very, very wrong and stigmatizing. And then other countries also declined giving priority because they said that the risks had not been sufficiently proven. So we launched a media campaign, really emphasizing that this is not sound policy, that the science has not been translated into policy and that things need to change. It was picked up by many newspapers, many countries, even in an editorial by Forbes. And I'm happy to report that following this campaign, we have seen a change in vaccination strategies in some countries. So already these countries had changed their policy prior to our work, but then these countries have changed following our campaign, then giving priority to patients with mental illness. Still, some countries persisted in saying that, the risks are not quite entirely exactly clear. So we gave them what they asked for. We gave them a meta-analysis looking exactly at which types of patients have which types of risks when it comes to COVID-19. And we saw that on the whole, with any psychiatric disorder, there is a higher risk of hospitalization, and there is also a higher risk of mortality, which is twice higher than in the general population. And this is particularly true for people with psychotic disorders and severe mood disorders, so bipolar and severe unipolar depression. And if we split that up by people with not severe mental illness, so these are all the other categories, and then the severe mental illness, this is the psychotic and the mood disorders, we see that on the one hand, the hospitalization rate is higher in the people with other kinds of mental health disorders than in the severe mental illness. But for the mortality rate, it's the other way around. So this is actually a very striking result. And we have since looked a little bit closer at this information. And it turns out that the one group of patients that has the highest risk of mortality, patients with psychotic disorders, including schizophrenia, don't have an increased hospitalization rate. So they're at a very high risk of dying, but they don't get hospitalized more often. So we don't know what that means. There are different potential ways to interpret this finding, but one of the most worrisome explanations might be that these patients, at least at that time in the pandemic, were not able to access hospital care and care in the ICU as well as people without such a disorder. Since then, we have summarized all the existing evidence, and this is work that we've done last spring. So there are now over 5 comprehensive studies, so systematic reviews, meta-analysis on infection risk, showing indeed some evidence of higher risk of getting infection if you have a mental disorder. There is also a higher risk of hospitalization, except for the psychotic disorders. No higher risk of ICU admission, but highly robust evidence for increased mortality, increased risk of dying, in particular for psychotic and mood disorders. So now we can really say it's been proven beyond a shadow of a doubt that patients with pre-existent mental disorders were a high-risk group during the COVID-19, and they have suffered immensely. And then it's extremely frustrating and worrisome that in this very high-risk group, we are seeing, again, first evidence about 1 year ago, lags in the vaccination. So even in a country like United Kingdom, where this group was given priority, we see that the rates are lower than in the other high-risk groups that were identified. So there is a problem. Mental illness seems to be associated with a lower vaccination rate. And now there has been a big debate going on in the scientific community. What is the cause? Are they just not willing to be vaccinated, or is it that they're not able to get vaccinated? Here in Belgium, we have demonstrated that if you actually create a targeted campaign, if you do a targeted intervention, really trying to remove all the different barriers that people may experience when trying to get vaccinated, that you can get vaccination uptake rates that are equal or even higher than those of the general population in people with severe mental illness. So of course, there might be cultural differences between different countries, and this was information from Belgium. But we do think that a large part of the vaccination gap that we are seeing is caused by inequity, by barriers that people are experiencing when trying to access vaccination, barriers that sometimes policymakers are not aware of. For instance, in many countries, if you want to get vaccinated, you need to go to some kind of big center, very big hall where there's lots of people, and you need to make your appointment online and go through different online modules to get your confirmation. This is simply not possible for many people with severe mental illness, either because they have problems with following up on administration, with doing online things, or maybe even because they're very anxious and they're not able to leave their home and go to this big hall where there's lots of people that they've never met. On top of that, even if they're vaccinated, we've also now seen that the antibody response after vaccination or infection is lower in people who already had a mental health problem before, and that they have a higher risk of getting a breakthrough infection. So they're not being as vaccinated as much as they should, and even if they are, they're not as well protected. And this has led, predictably, to excess mortality in people with severe mental illness. These are data from the UK that have been presented at the Congress, ECP Congress last week. So data from the UK Biobank and the Greater Manchester Care Records, showing, unfortunately, in people with schizophrenia, which is in purple, and in bipolar disorder in red, increased, so excess mortality higher than that of the general population throughout all the stages of the pandemic, even after the rollout of the vaccine, which is here with the dotted line. So no, the vaccination campaign has not helped these people or has not helped as well to protect these people from excess mortality. So it's time for action, and we need to do more for these patients in particular, because the virus is not gone, and we're still talking about the next round of vaccinations. I think many people are maybe in doubt if they will get vaccinated again, but for people who had prior to the pandemic already a mental health problem, or who have developed a mental health problem during the pandemic, I would absolutely recommend you to get vaccinated again. So these are my take-home messages, and I've talked to you about 3 kinds of threats from COVID-19 to our mental health. Firstly, in general, it's clear that our mental health took a hit during the pandemic. But secondly, there are these post-COVID complications, and I think these are still an underestimated problem. We also now know that mental disorders are associated with increased risk of COVID-19. And so there is a big need for better research on COVID-19 and mental health. This has been my lecture. I thank you all for your interest and open the floor to any questions.
Thank you very much, Livia, for this wonderful lecture. I am sure that our audience learned a lot, and personally, I learned a lot from your lecture. So I would like just to remind the audience that you have a Q&R section on the bottom of your screen, and you can ask some questions. And we already received some questions. I will start with question from Viorica Kursaru. What is the borderline between the anxiety and depression which all of us had during the pandemic and anxiety and depression which are really mental disorders? So what is normal or mild stress, and what is a real mental disease?
Yes, this is of course not new to the pandemic. This is a question that already was also posed many times prior to the pandemic. So many mental health problems exist on the spectrum, where there are very few people with no problems at all. Many people will at some point in their lives maybe experience some symptoms, but when the symptoms reach a certain threshold, and particularly when they start to really affect your daily functioning and your quality of life, this is when we would screen and probably diagnose a mental health disorder. But there are really criteria for that. So in many countries, the DSM or the ICD criteria are used to help clinicians really identify if this can be called a clinical problem or not.
Maybe I ask the next question, and I would also like to thank you very much for this clear presentation. I also learned a lot, but I have to say that was also quite a bit depressing, because it does show us that we do not know basically anything about what's happening in the brain. We see a lot of symptoms and a lot of syndromes, and it seems to be difficult to find a way through all these different symptoms that we are seeing. So thank you for showing us at least a few ways to get out of it. I have an anonymous listener, and I would like to ask you, Livia, please explain the abbreviations that are being used here. How do you manage POTS and differentiate temporary autonomic dysfunction versus more vascular endothelial-based issues affecting CVD? Have patients with post-COVID POTS recovered in your clinical experience?
Yeah, so the POTS referred to is the postural orthostatic tachycardia syndrome. It's a very difficult word for patients having autonomic problems, so problems in the regulation of heart rate and blood pressure. And we are seeing a lot of that following COVID-19, but it's something that already existed in some people besides COVID-19, obviously. But it's quite striking to see these kind of symptom clusters that are similar to things that we have seen in other types of patients. For instance, I think a lot of the features of the long COVID are similar to chronic fatigue syndrome, or similar to fibromyalgia, or similar to the POTS. And at the same time, this is making me a little bit optimistic, because maybe finally now, with COVID-19 and with all the research that is happening, we might finally be able to understand if this is really a sort of similar kind of mechanism involved. What is chronic fatigue syndrome and how to treat it? So I'm not totally pessimistic, but I think, yes, we are not quite there. And it's super, super important that we don't make the same mistake as with the patients with the chronic fatigue syndrome, to just tell them, well, we don't know, or it's psychosomatic, and go do some CBT, but it's not really helping them really recover. So I really think that this time we should dive deeper. We should really look at what is happening. And the person who asked the question is actually very right. As far as we know, when there are still several hypotheses being researched, there seems to be some vascular endothelial inflammation going on in COVID-19. So this means inflammation within the blood vessels themselves, or within cells surrounding the blood vessels. And maybe this can explain quite a few of these symptoms. Also the autonomic problems, so the problems in regulating heart rate, blood pressure, that might also be related to the invasion of the COVID-19 in the brain, in particular in the cerebellar region, where there is a lot of this ACE2 receptor. But yes, in terms of recovery, I'm not seeing a lot of recovery, neither are my colleagues. Some symptoms recover better than others, but if people still have cognitive problems after 6 months, most people still have them after 1 year as well. So the problems with the smell, for instance, those seem to do a little bit better, but like this fatigue and the memory problems, this is a big problem, and we don't have a cure for that as of yet.
Thank you. Now we have a question from Monique van den Eijden. Has any research been done on the impact of the online intervention, lack of face-to-face contact in mental health care?
Yes, I'm definitely sure there has been research, but I'm not so well aware of the findings. I think because I was at a conference last week in Vienna with ECNP, the posters that I've seen there on this topic suggested that at the very least it wasn't inferior to clinical contacts for most of the disorders that were studied, but not all disorders they had enough information to study. So I think if it's a question of having nothing or having something, it's always better to have something. And I was really happy that we had access to these online interventions, because for many patients, that was really their lifeline. But definitely for some people, especially people who were not yet in care when the pandemic came or who developed problems during the pandemic, they had real difficulties accessing mental health care. We've also seen, for instance, data from Germany showing that patients with depression, well, there were just as many patients with depression in Germany in the pandemic than everywhere else, but they were not being hospitalized to the rate that you would expect to see if there was just the same proportion of patients being hospitalized as normal with depression. And this rate went up and down with the infection rates. So their hypothesis is that, especially in patients with depression or with anxiety, they might have had real difficulties getting access to care, getting access to psychiatric hospital, maybe because the hospitals had some kind of restrictions, but also maybe because they were just anxious or not feeling free to reach out for help.
Again, should we take one more question? Or?
Yes, I think we can take 2 more questions.
Okay,
yes.
So maybe Catherine had asked several questions relating to her own case, and this may be interesting for the audience in general. She's asking, did you observe remission of post-COVID depression simultaneously linked to recovery of taste and smelling? So that's a question about, do the symptoms occur at the same time, and do they go away at the same time, or is there a discrepancy in the velocity?
We've seen lots of strange things, so I can't really say in general. I've seen really different individual trajectories. So on the most part, the research teaches us that some symptoms go away sooner, and the taste and smell is one of the first to improve usually. And then for the depression, anxiety, cognitive difficulties, fatigue, it can take longer. But yes, absolutely. I have seen very strange things of depression suddenly going away and then re-emerging, sometimes even after a vaccine, re-emerging, then going away again. But it differs really from patient to patient. So I think it's really important, and I would give the advice to everybody, if you have post-COVID complications, to really make good notes of when certain symptoms started, how they fluctuated over time, if you had another infection in between, if you had a vaccine in between, because those all may influence the individual trajectories.
Mm-hmm. So maybe the last question, but Livia, you might answer in the Q&A section later. So it's a personal question. Do you see any difference between the COVID pandemics and other type of stressors, either acute stressors such as terrorist attack or wars, which are longer stressors? This is the first part of the question in terms of mental health, of course. And do you see any difference in terms of the mental health consequences now that we are more habituated to this type of stress than at the beginning of the pandemic?
Mm-hmm. Well, maybe start with a message of hope. For the most part, humans are built to be able to cope with very stressful situations. And so this is replicated across the board in research looking at mental health consequences of traumatic experiences in general, earthquakes and disasters and terrorist attacks and so forth. So most people will initially have some kind of distress reaction and some insomnia or some anxiety, but a large majority of people, over 70%, will not develop a clinical mental health diagnosis. So for the most part, we are able to deal with these kind of challenges, but some people are more vulnerable to develop a mental health problem after any kind of major stressor. And again, we cannot predict right now who does or who doesn't. In terms of why or if the pandemic is different from other kinds of disasters, yes, I think it was for several reasons. Firstly, of course, the duration. It was ongoing stress for, well, at least 1 year and even 2 years, I think, in depending on the region. And some of the coping strategies that many people use to be able to deal with stressors and to be able to be resilient, for instance, reaching out for help from others, strengthening social ties, focusing on hobbies and on activities that you like, that was all not possible because we were not able to reach out to each other, at least not physically. People were, of course, afraid to infect each other. There were all kinds of restrictions on social contact. So the fact that we were not able to use social contacts as our coping strategy, I think this really created more problems for some individuals. Also, the fact that people sometimes lost all of their structure. They weren't able to go to school, go to work. Their hobbies were not there anymore. So total loss of any kind of normality in your life. On top of the isolation, I think this really generated a lot of problems. And then in particular, maybe in households where there were already some problems, some tensions or some unsafe situations for children and adolescents, I think this has been one of the main reasons why we're now seeing this huge increase in problems in that group.
Thank you very much, Livia, for this very nice presentation, for answering the questions. And I would like now to have a surprise for our audience, which is a video from the winners of a video contest launched by ERA-Net NEURON. The topic of the video also covers psychiatric disorders. As you heard and as you all know, mental disorders are a major cause for morbidity, mortality, and impaired quality of life. And to address this topic, ERA-Net NEURON has launched a joint transnational call for research proposals in 2018, involving 19 funding organizations from 16 countries, and the topic was mental health. And to provide early career researchers with the stage to present their research, we have asked the young researcher from this call to produce a short video showcasing their collaborative research project. And you will now see the video from our winner of the contest. It has been produced by a consortium called Discover. The young researchers were working together from all around the world on an innovative home-based non-invasive brain stimulation protocol that aims to alleviate depression with the help of a cognitive control video game. Following this video, Esther Deschamps-Streiter, who is a representative from this consortium, will give you a short presentation about this project. But let me now share with you the video.
Depression is a common mental disorder that seriously affects millions of patients' lives. Approximately 1/3 of patients do not respond to existing treatments like psychotherapy or medication. In addition, psychotherapy is not available for everybody. Thus, we need alternative treatments. We are an international team of clinicians and scientists collaborating to find a solution to this problem. Depression is assumed to be associated with a dysfunction of the frontal brain. Transcranial direct current stimulation, or TDCS, tries to normalize brain activity by delivering a weak electrical current to the brain. TDCS has less side effects than medication. Many patients with depression experience cognitive deficits. So we developed a video game with cognitive training tasks. We believe that the combination of the cognitive training with the TDCS helps to stop the circle of negative feelings and thoughts. For those who can't commute to hospital on a regular basis and for general comfort, we focused on accessibility by extending our treatment to the patients' homes. What does our treatment look like? Here's Mr. Miller at home. He has the TDCS device attached to his head, as he was trained to do in the clinic. On-screen instructions have guided him through the technical setup and helped him place the cap correctly. Now, he is ready to start the cognitive control training. Study staff is monitoring his treatment over the phone and through safety protocol emails. We've designed a new and engaging training world. Come see for yourself. Welcome to the Discover project, a new take on treatment for depression. For more information, please visit our website.
So now it's my pleasure to congratulate this team. And Esther, you are a representative of this team of young researchers, and you will explain us a little bit more about your project.
Yes, thank you, Etienne, for your kind words. We appreciate them very much. So my name is Esther. I'm a research assistant from Munich, Germany. My role in the project is the coordination of the study treatment. I'm happy that I may present our Discover project on behalf of the Discover Consortium today. Since you are coming from very different backgrounds, I'm trying to break down the project to the most important facts. The Discover study is an international clinical study combining a cognitive control video game and TDCS for the treatment of depression, as you have seen in the video already. The trial is currently running and we are looking for study participants. Let's have a look at the trial's design. Potential study participants undergo study visits before the treatment to look whether they actually meet our inclusion criteria and to assess their baseline status in depression scores and in cognitive functioning. The treatment phase contains 6 weeks. To ensure that the observed effects are actually due to our active treatment, we need to compare the treatment group with a so-called placebo or control group, receiving a treatment that looks and feels similar to the active treatment, but is not expected to target the same mechanisms of action. According to good scientific practice, we assign patients randomly to one of these 2 groups. To assess treatment effects, we ask patients to attend study visits again after treatment completion, one directly after the treatment and one at a 4-week follow-up. For the patients who feel supported throughout the whole treatment period, we train them on how to use the treatment device in the clinic during the first week, and we supervise them during the remaining 4 weeks of home-based treatment. The treatment takes place in study sites in Israel, Latvia, and Germany. Study sites that develop the treatment components located in Switzerland and Italy and Israel are available for ongoing technical support. In total, we want to recruit 114 patients with depressive disorder, aged between 18 and 65 years. As you have seen in the video before, we daily apply 30 minutes of low-risk TDCS and a concurrent video game training cognitive control. Which study outcomes are we interested in? Firstly, we want to know whether our home treatment is feasible and safe the way we developed it. Secondly, we want to know whether the active treatment leads to an improvement in depression scores. And thirdly, we want to investigate whether it results in improved cognitive control functions in depressed patients. Demonstrating the feasibility, safety, and efficacy of our home-based treatment could expand the spectrum of treatment options for patients with depression. Such home treatment could be integrated into activities of daily life naturally, and it may help to overcome barriers that often interfere with treatment compliance, including difficulties to frequently attend doctors or the clinic, an issue recently amplified by the COVID-19 pandemic. Thank you very much for your attention.
Thank you very much, Esther. This was a glimpse into real research, into the lab and how things work in a lab and how you recruit patients. Thank you for telling us about this, and thank you for the nice and funny video clip. We will post it on YouTube as we are going to do the entire session today.
Thank you, Marlies.
Particularly thanks also to Livia again. That was a great overview of what's been going on in the past years and what we know about mental health and COVID-19. It was an inspiring talk, as I said, a bit depressing, but that is a beginning of what we need to do, and it shows how much work still needs to be done. And I would like to thank the audience for listening to us, for listening to this ERA-Net Neuron lecture. I hope that you could learn as much as I did. And Etienne said that even you learned a lot from this session. So that was very excellent and very good to understand. And we had questions that showed that the audience did understand what you were saying. So thank you for the style that you were using. It's also very, very important for us. Etienne, thanks for organizing this and for inviting our speakers. And thank you also to the teams who helped organize everything and set everything in place. Our teams in Spain and in Israel and Germany and in France. And as you can see, this is really a transnational endeavor. The ERA-Net neuron is really combining as many countries in Europe and outside Europe as possible. And with this, I would like to wish you a nice evening. We have a lot to think about, so that would not be a boring evening. And have a good weekend and relax from all this work and exciting new stuff that we learned. Thank you.